Greetings. Hello to all of you. I'm Beth Lown. I'm going to wait until the audience starts to fill in a little bit. We're glad you're here. It's going to be a fantastic discussion. So we're seeing more and more people joining us. We'll wait just a few more minutes. And then we'll get started soon. All right, I think I'm going to begin. Welcome everybody to today's Schwartz Center Compassion Action webinar, Expanding and Diversifying Pathways to Health Professional Education. Thank you so much for joining us. I'm Beth Lown, Chief Medical Officer here at the Schwartz Center. And as many of you, of course, know, we are a Boston-based nonprofit organization established in 1995 to advance compassion in healthcare. We are honored to be able to offer this series of Compassion Action webinars thanks to a very generous donation made in memory of Julian and Eunice Cohen. And we are particularly honored and excited to be able to host today's very important conversation. I do want to acknowledge and apologize for inadvertently scheduling this webinar on the second day of Rosh Hashanah, the Jewish New Year. We're very, very sorry that some members of our community who observe the holidays are not going to be able to attend, but a recording of the webinar will be available on our website tomorrow. And again, our apologies. But today we are going to hear from just an outstanding group of leaders in health professional education about how we can work together to increase diversity in our professions, in leadership, in education, and of course, why that matters. Very briefly, before we get started, I'd like to note that today's program will last about 60 minutes with a moderated panel for the first 45 minutes or so, followed by some time for your questions. So please do feel free to enter questions in the Q&A panel or the chat throughout the discussion. We'll keep an eye on them as we proceed. And with that, I'm very, very pleased to introduce today's panelists first and then our moderator. Please join me in welcoming our panelists, Dr. William McDade, Chief Diversity, Equity, and Inclusion Officer at the Accreditation Council for Graduate Medical Education, ACGME. Welcome, Bill.
Thank you, Beth.
Dr. Joan Reede, Dean for Diversity and Community Partnership, Professor of Medicine at Harvard Medical School. Welcome to you, Joan.
Thank you.
Dr. Deborah Trautman, President and CEO of the American Association of Colleges of Nursing. Very much looking forward to hearing from all of you. Thanks for being here. And I am very pleased to introduce our moderator for today's event, Dr. Teresa Smith. Dr. Smith joins us from SUNY Downstate Health Sciences University, where she is the Associate Dean of Graduate Medical Education, designated institutional official, and an emergency room physician. So I am emergency medicine, not emergency room. I'll hand it over to you, Dr. Smith. Thank you.
Thank you very much, Beth, and thank you to the Schwartz Center for hosting this very important conversation. So I'd like to start off by saying, as Beth had discussed in the introductions, we're going to be talking about how to diversify the physician and nursing and all professional health professions workforce. How we do that so that we are creating comfortable learning environments for all and really trying to get at the root of what the problem is currently here in the United States. So just to give out a little bit of stats, so Black, Latino, and Hispanic and Native American people constitute only 11% of US physicians, though they make up 32% of the United States population. That's not enough of the doctors and nurses working in our hospitals, mirroring the diversity of the patient population that we work with. So our discussion today is to talk about how we can collaboratively create an effort that we can work to not only diversify the workforce through intentional recruitment strategies, but also to support those diverse learners and faculty within our institutions. We must not only create the pathways, but also ensure that we heal the cracks in the system that can lead to attrition and unsuccessful completion of training. so that we ensure that we can get to the ultimate goal, which is having more diverse practitioners. So let's get started. And my first question is for all of the panelists. I really want to identify the problem. So where are we with diversity in the health professions workforce? How far have we come? What are the implications of the lack of progress on diversity in health professional education from students to leadership? And feel free for any of the panelists to begin and start us off with answering that question.
I think we're all being polite. So I'll take the lead on this one. So where are we? If I were to show you data from the ACGME on the number of Latinx, African American, and Native American physicians who are in graduate medical education training over the last 15 years, you will see that there has been almost no progress. The same percentage in 2004, 2005 is what existed in 2019-20. Last year, there was a slight uptick, so that the numbers of African-American physicians has risen from about 4.8, 4.9% to around 5.7% in this last year. That's a very positive thing. If you look at undergraduate medical education, you'll see that for African-American physician, African-American medical students, first years, that last year was the first year that the applications were up significantly from previous years. And that really speaks to the idea that there's been a long-term effort to try to drive this. And last year during the pandemic, I think there's been some heightened awareness around the importance of healthcare. So I think when you look at what's driving the increase, I think we're making some progress in terms of trying to increase awareness around the importance of diversity, equity, inclusion. And I think it's also that we've had circumstances that have called people away from other fields that they might have otherwise thought about with the COVID pandemic. And so I think we should take advantage of that, get the best and brightest in medicine, and to keep moving forward in that pathway. I could comment on why it's important for diversity, but I'll leave that to my colleagues. And if we have to circle back, I'll tell you a few of my ideas on that one too.
Well, and I'll jump in now also and add that in nursing, while we have been steadily making progress, we are still predominantly a white female profession, but there is some good news to celebrate. And that is that when we look at faculty, out of the faculty that teach in baccalaureate and graduate programs, which is nearly 50,000, we currently have about a 20% are underrepresented groups. And the good news, if you will, it's still a very low number, but it was 16% in 2017. So there has been intentional effort that has helped us to raise the diversity. A challenge, but will also be an opportunity, is that we are experiencing national faculty shortage. It was 8% last year, and it's now approaching 9%. So this will allow us the opportunity, again, to be even more intentional about recruiting and diversifying the faculty. In our student population, which is baccalaureate, that population I'll speak about today, but it's true across all of the types of nursing preparation, we still once again are predominantly white female, but we do have some variability based on the type of program. So for example, we've seen the greatest increase in males. It's now 14%. It's 10 to 14% across all programs, but the highest percent, 14%, is occurring in the Doctor of Nursing Practice programs. As the national workforce overall, so once we have individuals out working in practice in a variety of settings, we now are at a 69%, 69% are still the white male and female population, but we are seeing that 30% is better than it has been. And because I would say that the efforts are in recruitment, the holistic review process has yielded very positive results across the health professions. But a concern that we all have is we're likely to begin to see we are seeing some declines in enrollment in some of the health profession programs. Let me turn to Joan.
Thank you. Both of you have given, I think, important numbers for us to understand, particularly as it pertains to our students and student entry and recruitment. I think we haven't talked as much about retention and advancement. and how this translates into individuals who become our fellows, who become our faculty, who become our leaders across our institution. And today, as it has been historically, there is an underrepresentation of women and people of color, Black, Hispanic, Native, the groups that we normally talk about as underrepresented, but also Asian, as you move into looking at the leadership positions. So as you start to look at who are the full professors in our institutions, who are the department chairs, who are the deans, across the board, there is this lack of representation, improving somewhat for women. But when you start to look at intersectionality and you're looking at gender and you're looking at race, ethnicity together, still striking issues in this space. And for me, what's interesting is you start to look at the data and let's say, well, the Hispanic women are a little ahead and they're a little ahead of the Black women and these others. But this is a small piece of the pie. And we're talking about sort of arguing about who's got a little bit bigger piece of this small piece of the pie rather than substantive change. And I think we need to look at this more holistically. It's not just about entry. It's about, for me, how do we change this system? How do we change this landscape? How do we understand that it's not just, even as we talk about these issues, be it in nursing or medicine or across the board, is we're talking about the kids who enter, they can go into any of our fields. This is not like this siloed thing of this competition. This is how do we get the best and the brightest period in our space? And then how do we move people into positions that can think about how do I change the learning environment? How do I change the culture of the environment such that it is more inclusive? And with that, I think for all of our health professions, it's how do we operationalize the values that we put forward, the values about equity, the values about social justice, the values about inclusion, the values about distributive justice, and how do we make sure as we're setting our policies and practices, they're consistent with those values? And how do we do this with an eye towards this is not about diversity and inclusion in isolation. I think all of us are here because we truly believe we will be better. That we will move more towards excellence. We will deliver better care. We will be able to advance our science and ask different kinds of questions. This is all done with an eye towards how do we deliver better healthcare? How do we do better research? How do we educate better? And this diversity and inclusion are the bedrock of part of that, the different voices, the different perspectives.
Great. I think, does anyone else want to touch on the impact that diversifying the workforce would have?
Well, maybe I'll circle back one more time. One of the things that is interesting about how we are structured as a healthcare system with respect to diversity really doesn't stem from anything that's happened recently. I reflect back on the Abraham Flexner report back in 1910, which really established the tone for medical education over the last century and plus. And in it, in chapter, I believe 14, there was the mention of the education of the Negro physician. And when the Flexner report was written, there were 7 African-American predominantly medical schools that were open. After his report, that dropped down to 2. And those 2 are still in operation to this day, Howard and Meharry. And what you did when you reduced the number of African-American serving schools is you reduce the flow of individuals from those schools for the next 100 years. And the rationale for keeping those 2 schools open was because Flexner said, you have to have physicians who are going to take care of the Negro population because they're capable of spreading disease to the white population, and that you're not going to have white doctors to care for them. And that's really the self-fulfilling prophecy that's actually occurred over the last 100 years. We see when we ask first-year medical students on the matriculating student questionnaire whether they're going to serve the underserved, if you look at African-American students, about 60% say that's what I'm going to do. For Indigenous, about 55%. For Latin students, around 50%. But for white and Asian students, it's in the low 20%. Do we change that after 4 years of medical school? The answer is no. The graduation questionnaire shows the same numbers. So what we're doing in medical school isn't changing the minds of those individuals who were not focused on trying to treat those communities to help us to eliminate health disparities. And what we've relied on is this concordant care that was prophesized in the Flexner report And that's still, unfortunately, how we see most of our patients, and it's on the basis of race. And unfortunately, that's insufficient when you don't make enough diverse physicians and nurses and the other healthcare practitioners.
I think the other part that has become, it's always been, so none of this is new, that this is these injustices, this imbalance, this discrimination, all of these things are embedded in the structures of how our schools were formed, how our profession has operated over time. And with that are the disparate outcomes from disparate treatment, disparate, and just things that you sort of say, how did you come up with this? How did you come up with the idea that Blacks feel pain differently? I mean, stuff that for us in science, we should be saying, are you serious? But it's embedded in part of our society. It's embedded in our structures. It's embedded in how people think and how they practice. And some of this diversity is having people who will ask questions, who will say, why are we using these algorithms? How are we coming up with these systems that actually increase the disparities that we're seeing? And we need people with different lenses in the room to ask different questions, to do different kinds of research. What COVID did for me so beautifully was to help us understand the advances we've had in science, where we did something absolutely remarkable in terms of a vaccine so rapidly. Remarkable. But helped us to also understand that science by itself cannot eliminate the disparities. That science by itself is not going to address all of these other issues, that the things that Bill is talking about, that were embedded in Flexner and embedded in our systems and practices, that stop us from being able to reach certain populations, that do not address issues of trust, that do not address issues of access, do not address issues of preparation, things that have been here, but it just made them so starkly clear. But it also points out part of how different voices are also heard by different communities, and how different individuals and representing different populations had to step up so that they could be trusted, so that the communities would accept them.
Absolutely.
And I personally believe that until we as health professions look more like the diverse communities in which we live, there's always going to be this differential that we must think about how we are not just, as you said, bringing individuals in, recruiting individuals to the health professions, but what we're doing to sustain and support success, and then a full integration when we are in these different practice environments. I think that, I personally think that we will have a more satisfied health professions workforce. I know that's a journey yet but I believe fundamentally that would be an important outcome that we have not yet achieved. And I don't want to get too far ahead. I know we're going to address.
But Deb, I just want to add a piece to that, as you're
Sure.
saying, because the goal for me is not to change the picture on the wall and having, so it looks different and there's more representation. There are people who might look like myself. But with that representation, our system will actually change.
Oh, no, and I mean the same. I think
Right.
that I was a part of an academic health center that historically has been criticized because those who lived within the walls, if you will, of the health center are very different than those in the community. And it continued to perpetuate a hierarchy that should not exist. So I look at that. So that's why I think it's important, but I understand what you're saying and I don't disagree.
Absolutely. So now I want to go to the how, right? The pandemic, has really enlightened us on many things, and really has driven home the point that there's a sense of urgency to this, right? So this question is for Dr. McDade and Dr. Reede. Where do we need to go with increasing health professions workforce? How do we increase diversity in the health professional education collaboratively so that we're not doing it in silos? And what extra support measures are needed to be in place given the pandemic's impact on pathway programs?
Dr. Reed, you've started this off, and in terms of thinking about what COVID's impact has been. The idea that pathway programs have been adversely impacted is something that you clearly know about, but I think that it also offers an opportunity. I think that when you had no opportunity to bring people together in that way, and you had to do it remotely, you reached a larger audience. You had people who were potentially denied an opportunity to participate, the opportunities now participate. You could expand the effort that you had. I'd say the collaborative element of this is something that the ACGME has really driven with its common program requirements. And that is, prior to that, the Liaison Committee on Medical Education, the undergraduate accrediting agency for allopathic medicine, put forth these ideas that pre-medical students should be the target for medical schools to try to bring more people onto the pathway into medicine. But there wasn't a parallel request of graduate medical education. And we have a number of programs in graduate medical education that don't have medical schools, that didn't have that requirement. And so now they do. They have the same sort of requirement to reach back to help younger learners come onto the pathway. Because I think that's the solution. We have to increase the size of the pie of diverse individuals who are in our profession. And it starts early, but it also starts late. I think one of the targeted groups that gets overlooked because they're really the walking wounded are those people who are in post-baccalaureate programs. They've been damaged by their experiences as undergraduates, but they're brilliant individuals who, if we can find ways of reclaiming them, we could bring them into medicine quickly. But I think it also starts with those educational determinants of health that Dr. Reed was referring to, those other things other than the science and medicine aspect of what we do that really can impact those younger learners to help them increase their ability to come into the profession of the healing arts.
Thank you. You know, I agree totally with this. I think that there is no aspect of our sort of professional space, if you think of this trajectory from early to where we are as we sit here, where there is not an opportunity or a role for us to play in this. And that a friend of mine, also probably of Dr. McDade's, Woody Myers was at one of the programs I did years ago, and I had all these students from all over the place, and he talked about them as pluripotential stem cells that could go in any direction. And how do we start to think about this as we, on one hand, talk about this integration and our disciplines working together in different kinds of teams and different kinds of settings, but also for us to be able to think early on about how do we recruit people across disciplines and work together to identify and nurture and help younger individuals discover and explore multiple career paths. So it's not just the career path of how do I become a doctor, a pediatrician like myself. It's how do I become a nurse? How do I become a technician? How do I become a dentist? All of these career paths and what's right for them. I want to speak to another small piece of that, and it's in this light of what we can do in terms of collaborating. And I'm going to use the example of something called the Biomedical Science Careers Program that's over 30 years old. It was started here in Boston, started out of my office here at Harvard Medical School and spun off as a separate 501c3. But it is an organization that involves people from across all of our disciplines. So from nursing, from dental schools, from medical schools, from community health centers, from private industry, biotech, pharma, device, community colleges across the board, professional associations, of how do we work together to identify individuals? How do we provide them resources, information, advice, and mentoring to help them as they move through whatever that path may be, understanding that people need multiple points for entry, exit, and re-entry. It makes no sense to think that early on, someone's going to figure out what they're going to be doing 10 or 20 years from now. But how do we provide them supports for transition points? Are they going to come onto our faculty? Are they going to go into the hospital? They're going to go into private settings, all sorts of things like that. How do we think more expansively about who can collaborate in this space? And how do we support it? How do we fund it? how do we, so BSCP has had over 15,000 students all the way up through junior faculty and early career professionals involved. It involves identifying resources and funding support from across the board, and actually takes no public funding. It's how does our community come together to support this? And with it, how do you get these voices from these multiple sectors that don't see it as hierarchy? Deb, you talked about this idea of hierarchy. How do you take the hierarchy? It's not that one profession is better than the other. It's about all of them are good. All of them are needed in our healthcare system. And do this in a way that says it has to be continuity. That all too often our programs target one level and there's nothing to help transition people to the next level, to transition that medical student to the residency, to the fellowship, to the junior faculty or whatever, that we are not really thinking of it as a career. We're thinking of it as drop-ins at like one point in time. So for me, this requires that we collaborate. We collaborate across our systems. We collaborate across our disciplines. We understand that to actually do this work, we have to work with our community and broaden our sense of understanding of what community is. So when I look at BSCP, the medical schools are involved. The residents and fellows in the training programs are involved in it. It's how do we collectively work on this problem or issue?
Thank you. And I would just, Joan, I so appreciate what you're saying. And when we were prepping for this session, I recalled, which I had stored back in my memory, extraordinary experience that I had as a nursing director when a trauma team went out into the community to talk to high school students. And it was a very interprofessional team. And we went out and shared some of what the joy, the satisfaction we have in our profession. We found and stimulated interest within the community, and we ourselves as a team enjoyed the experience. And then after our prep session, I reflected, I don't know that there's many of those types of opportunities, even something that finite and simplistic, that it hasn't taken off yet. So we, I believe, need to be more intentional. And I personally, even though I'm a perpetual optimist, there's still significant competition within the health professions for clinical space, and we have common problems and oftentimes see these solutions should and do go across all professions.
That's excellent. And I love the picture and the imagery that you created. So, Dr. Trautman, I want to talk to you about the nursing shortage and going back to the reference of the pandemic. So the pandemic has brought about, what many are calling the Great Resignation. Workers from many spectrums of the workforce, particularly in medicine, have changed their careers. There's no greater area that this has become evident than in nursing. So we are now in what many are calling a nationwide nursing shortage. So what are the reasons behind this great nursing resignation? And in general, what should be our goals to address the nursing shortage?
Well, thank you. As you noted, the pandemic illuminated the critical importance of nurses, the extraordinary profession that nursing is. And it also provided, it was very disruptive to the workforce over time, especially, the first couple waves. I recall all the health professions, but in nursing in particular, we were early on pleased to see a spike in the interest of nursing during the pandemic. And in part, that had to do with, many believe, a greater understanding in the public of the contributions that nurses were making in this critical time. But we have since seen, as you noted, we had a great resignation occurring actually before the pandemic because we had an aging workforce and many nurses were at a retirement age. By some reports, that number was 1.2 million were retiring before the pandemic. And then I believe that after multiple surges and increasing shortages in the delivery system and the personal as well as the professional challenges, there were many individuals who were close to that retirement who also made a decision that perhaps this was the time to step away. The good news, if there is any in all of this, is that programs, academic programs in nursing have accelerated enrollment opportunities. So we've seen just from, look at my data from 2001, so this is way, of course, before the pandemic, we've seen a 265% increase in the number of graduates from entry-level programs. So where we had just over 22,000, now we are graduating 82,000. And while that's good news, the demand continues to grow. The Future of Nursing recently released a report 2020-2030 that was supported by the National Academy of Medicine and the Robert Wood Johnson Foundation, projects that we're going to see an increase of at least 9%. So we must do more to attract individuals into the profession and provide opportunities. In nursing, unlike the other health professions, although over the last several decades, we have increasingly been coming together, academia and practice used to be very separate environments. That is not a sustainable model. We must integrate academia and practice and together provide these innovative solutions and have faculty crossing over. Medicine has done this for quite some time. Very few people live in one community or the other, I would say, from what I understand. And I think that's beneficial as we think more about what to do in nursing. With respect to recruitment, we are watching enrollments because, again, across all health professions, but we are starting to see declines in interest. And some of that is not related to the pandemic. It's not related even to the shortages in the healthcare delivery system, but some of the recent news around holding healthcare professionals legally responsible for mistakes has had a negative unintended consequence. It's not been the significant percent, but all of us in the health professions need to be very cognizant of the consequences of these kinds of decisions. And when we know to err is human. I mean, we know about what we're all humans, and we need to continue to do more to help individuals understand how the healthcare system will support those who are supporting our communities. In nursing, in addition, we still have most of our practitioners in acute care, and we need to do more to open up opportunities. There was another report from the National Academy of Medicine about primary care and how we must increase nursing, not just advanced practice, which is important, but also entry-level nurses in primary care and public health. Across all disciplines, we know that we have a public health shortage. So I think being intentional about providing those opportunities and working on supporting the distribution where we need that distribution most.
Thank you.
Mm-hmm.
Thank you. So I want to go and talk a little bit about our retention efforts and looking at it, as we've all discussed, as a pathway with multiple entry points, and how do we not only work upon those entry points, but make sure that we don't have a lot of exits either, right? And so we have this concept of the social determinants of health professional education, and it's being used in the similar way that we talk about the social determinants of health, such that we have upstream issues. And if we look at health outcomes, those upstream issues would be food insecurity, job insecurity, a lack of housing or unsafe neighborhoods. And all of these upstream issues all determine the downstream outcome, which, if we're talking about health, that would be the patient's health. So if we look at the social determinants of health professional education, some of the upstream factors can be student loan indebtedness, a lack of STEM exposure in K through 12, a lack of mentorship, and the impact is the diversity in medicine. So Dr. McDade, in your article in the Academic Medicine that just came out in July 2020, you discuss how, particularly in the time of the pandemic, academic medicine should reflect and reset, right, on its trajectory toward achieving diversity and improving inclusion, and also combating racism. So some of your reflections can fit within this social determinant of health professions framework. So my question to you is, how do we stop putting the burden on students and transfer this to the entities like medicine that would benefit from more learners? How do we support our learners?
Well, I mean, there's so many things that we can do. I think that the idea is that within a program, within an institution, we have to generate a sense of belongingness, first of all. We have to figure out how to take down barriers that would otherwise cause obstruction that would be inequitable. That is, that some of the problems that minoritized learners face are different than the ones that people of the dominant culture face. You look at the wealth gap that exists in society, another social determinant of health, where it's 10 to 1 with respect to white families and African-American families. When you think about how you have to prepare to go to medical school, and the amount that it costs in order to apply to medical school, in order to prepare for the examinations, all of those things are weighed with the thumb on the balance toward the dominant culture. Minoritized individuals can't afford prep materials. Minoritized individuals are often excluded from learning environments that other people benefit from. And there's the additional burden of internalized racism, so that a person may feel imposter syndrome in the environment that they're in, such that when they get into that environment, they don't want other people to know what they think they don't know, not realizing that everybody doesn't know this as well. Now, there's some legitimate things that people don't know because of the under-resourced backgrounds that sometimes people have come from. But I tell you, what people do have is resilience. People do have grit. People do have determination. And these all can be recognized and heightened by the things that we do by recognizing what people are able to bring to their environment. And that's part of belonging. It's to allow one to bring one's own self to that environment and to contribute in ways that other people may not be able to contribute. And this is what Dr. Reede was talking about before when she was talking about a holistic approach to how we make our classes. Are the people who we're bringing in consistent with our mission? So that's another structural thing that we can do. We can set our mission to be elimination of health disparities, serving the underserved. And if we then want to fulfill that mission, then to select classes, select programs, individuals in your program who are consistent with that particular mission. What you can do at the level of diversity that's really important is by creating the leaders, again, that Dr. Reede talked about and Dr. Trautman talked about, was the idea that physicians and nurses have an outsized role in society where they can actually be advocates in ways that other people aren't as heard. And so when you say, for instance, as one of my former places of work, the University of Chicago did, we're not connecting with the community sufficiently. We're not providing those resources that are necessary for good health for a community. And they rented a space for a chain grocery store to come in and set up an operation in a neighborhood that hasn't had a chain grocery store in 30 years. And this was to provide that community with better access to nourishment, food that would actually help them live longer. And this is the advocacy that comes from diverse physicians in that environment who said, this is something the community needs. This is something that we can do as an institution to change healthcare outcomes in that community that transcends what we're able to do in the clinic exam room.
You know, to follow up on pieces of that, and because I think it's important to understand that even as we look at the matriculation or graduation surveys and students of color more likely to say that they want to serve certain types of populations, marginalized, disadvantaged, vulnerable populations, that's not the reason to accept them into medical school. And that's not their purpose as physicians. The purpose should not be defined by others. It should be defined by themselves for what they want to do and where they want to go. And it's, I remember if I go back to when I was applying to medical school, and it's many years ago, many decades ago, and it was understood by the students that when they asked you what you want to do, you had to say, I want to serve, I'm a Black physician, I want to serve minority communities. It's sort of that Flexnerian sort of approach. And if you said anything else, it'd be like, what? If you were to say, you know what, I want it because I want to be a Nobel laureate, because I want to be a department chair, because I want to be commissioner of health. If you said anything else, it would be like, it doesn't make sense. So the reason for this diversity is not just to serve minority communities, minority patients, although that is an important element of this, but it should be based on what that individual, that nurse physician wants to do with their career. They're needed in so many different places. I've alluded to some of the lack of presence and leadership. I think what they do in our institutions is what Dr. McDade just talked about. It's not how my being in this section of Boston and the service that I give to the community. I worked in community health centers in Boston and prisons in Boston before I ever came to Harvard, improves the health of the community. For me, the question is, how does my being at Harvard help Harvard improve the health of the community? And that's what this grocery store example is it's the institutions, it's our professionals' obligation to make a change and make a difference. And how does my voice, my presence change the conversation? How does the culture and environment change such that it is more consistent with the needs and has a better understanding and is more responsive to the needs of diverse communities? So it's not just being present. If I'm here and I don't have a voice, if I don't belong, if I'm not a part of the system and how we change the system, you're still missing part of the benefit that I can offer to the organization and to the profession. It's how do our institutions deliver on their responsibilities? How do our institutions actually live up to the missions that they profess? And part of this diversity and this excellence enables our institutions to do that.
Absolutely, absolutely. And Dr. Reede, this final question is for you. So with a call of action for all of our fields in medicine to increase the diverse workforce, there's a call to increase the leadership in medicine. You kind of alluded to that, such that there are more diverse people making important decisions at important tables. And you talked about that a little bit in your New England Journal article that came out in April of 2022. The proportion of underrepresented medicine leadership representation as compared to the US Census remains either the same or maybe even worse in some cases, in some groups. So even the relative moderate improvements in the underrepresented in medicine medical student representation has not seemed to translate down the path to faculty, particularly in rank and chair and dean positions. So what are the steps to increase the diversity of the leadership of medicine? What are the implications of doing that as well for the trainees and the other learners?
Yeah, so part of it, I start in, I come from an academic institution. Part of it is to start and examine the data and where's the evidence. So people are surprised when you start to look at it. A few years ago, when we looked, say there's 175, 180,000 faculty in US medical schools. And at that time, there were roughly 300 Black female full professors. So when I had a dinner with 4 Black female professors, I had a large percentage of all the Black female professors in the country at my dinner. That makes no sense. So how do we begin to look at the data? But then I think about the world of health disparities. If you think about the history of health disparities, it would be, no, there's not disparities. And it's, well, yeah, there are disparities, but they exist over there, not here. So how do I move from these are the national data to what does it look like in my own institution across these different levels? Are my medical students staying here for my residency programs? And are my diverse medical students staying here in the same way that as my majority students are staying here for residency programs? Who's going from my residency programs into my fellowships? And how is the transition to faculty? And is there a difference across that transition to faculty? Am I retaining faculty? If you look at nationally, there is a problem with retention of faculty. Even if they enter, they're more likely to leave if they're faculty of color. What is happening with that space? As I'm looking at my recruitment, that's internal. As I look at my recruitment from outside, what does my short and long list look like? Who am I inviting in for interviews? Who's moving into those positions and getting both promoted and recruited? Those are data that our institution should be tracking and understanding. And when the results show a pattern that is indicative of exclusion or not inclusion and not belonging, we should be questioning it. One of my issues when I think about issues around diversity, all too often our institutions are doing what they feel feels good and feels right. But when we do everything else that we do in medicine and healthcare, we're asking, where's the evidence? Where are the data? How are we improving? Where's this quality improvement? This isn't working. What are we doing to change it? Why aren't we doing the same thing as we look at this diversity space? And why isn't there an expectation of us for improvement? So I would start in a space of examining that both from a national, from a regional, from our own institution, what is actually going on? Are there differences? Are there parts of our institutions, if you start to look internally, sometimes one discipline is doing better than another. What are they doing differently? How are they recruiting differently? What are kinds of programming? What kind of mentoring do they have? How is the culture difference across these spaces? We should be examining and understanding this? Do the networks look different across disciplines? And then we should be very intentional. How do we identify talent early on? Okay. And are we in our institutions, as we identify talent, are we identifying talent that looks like the people who are already in leadership? Okay. Or are we looking at potential? Are we looking at individuals who may think a little bit differently? I think about the fellowship programs I have where people are coming in who are thinking about doing things I have never thought of. It's exciting, it's innovative, it's entrepreneurial, it's what we need in medicine. And so how do we raise that? How do we protect individuals from all of the other kinds of what they call the diversity taxes that we put on them? Can't you do your clinical care and do your research and publish and mentor and help us recruit and serve on all these committees? Well, I won't count any of this work that you do that helps us achieve our mission. How do we come to grips with us setting up systems of imbalance in terms of what we actually value and recognize within our organizations? How do we start to provide positive feedback? How do we sponsor? How do we put people forward so they're more visible, that they have opportunity to learn the system, that they get mentored and guided and protected along the way? So to me, this is about intentionality. It's about doing our diversity work in the same way that we do our other work, where there's evidence and data and tracking and accountability and expectation for positive change. And how do we move this in a direction that says it's not owned by a diversity person or diversity office? And for many institutions, many parts of organizations, they've started to hire a chief diversity officer, or they'll find a faculty member and they'll say, we'll give you 0.05 FTE to do all the diversity work for everything. Not reasonable, not reasonable. How do we do this in a way that says this is something that's owned by our institution? It's owned by our leadership and across the entire organization.
I'll also add that often they're not given funding to do the work. So
Absolutely.
magically the work gets done with a lack of funding for their departments or divisions that were newly created. And so
Lack of
somehow
funding, lack of resources, but titles. We are very good at giving out titles.
Yes, titles. So I'm going to go to Beth, some of the Q&A questions, and if you'd like to help me filter through. I think we answered the first question, but we have another question from a participant who is describing one of her mentees who comes from both an LGBTQIA background and a Latino Hispanic background, and really talking about the medical school admissions process and how we can create equitable admission seats, right? That is one of the entry points that we talked about. Any conversations on that? And I'll even expand that to not only medical school, but all entry points, right? So nursing school, then going into residency training if you're a physician, or being able to get your great first job as a nurse. How do we create equitable admissions so that we're not just saying that we're going to diversify the workforce, but we help our colleagues in the ways that they can actually do that and select the candidates?
I think a lot of great comments have already been made, but in addition to, of course, mentoring and support the recruitment and supporting one throughout a successful academic program, then facilitating the transitions. I think recently someone spoke to our membership and challenged all of us to look at intentionally, who are we mentoring? And if we're not currently ourselves participating in a robust mentoring with individuals who do not look like us, but look different than us, then I think that's one of the opportunities. Holistic review for all the schools has been positive. So I think we need to, as both Dr. McDade and Dr. Reede said, we've got to continue to look at data that shows what strategies are making a difference, and then roll those forward and across all health professions. I would add one comment to what I think was implied, but that Dr. Reede said, holding the institutions our institutions responsible and accountable, but also our professions. When I started in my nursing education program, it wasn't about the community as much, a little bit, maybe the immediate vicinity of where I was. But we're talking that we have I think, over the course of my career, a much more significant call to not only make a difference in the lives of the individuals in the communities that I serve, but in the greater population. And how we do that is by being intentional, but also self-awareness and calling ourselves out. There are well-intended missteps, and we have to call ourselves out about them.
You know, as you talk about this, because I didn't say it, but what you're saying, I think a lot of this begins with self-examination and how do we make ourselves aware, and understand that all of us misstep all the time. It doesn't mean you don't try, you don't move forward. You understand it, you acknowledge it, you work with others to build situations where we ourselves are changing our own networks. So if the network that I work with thinks like me, trained like me, looks like me, and then says, Joan, you know, that's a great idea because you think just like I do, then there's a problem with that. And how do we expand that? And the people who will challenge us to grow and to think differently and to move beyond. So I do think part of this actually begins with self. I just don't think it ends with self. And historically, we put too much of the burden on individuals while organizations, be they our academic institutions, our clinical settings, our professional organizations, have been able to slide. And they need to step up. And when I think about this idea of holistic admission, I think even when I think about not just admission to medical school, I think about to what extent are the criteria that we are holding up as our values reflected in the criteria for how we select individuals. So I mean, I think about residency and training, and what are you training people for and to become, and to what extent is you're making your selection of residents and in graduate medical education, is it reflective of the product that you want in the end? What are you training people to do and to become? And is that process holistic?
Well, let me just key in on one quick one that answers one of the questions for a mentor of a Latinx individual. Many schools offer fee waivers, so that if you apply and you qualify for the fee waiver, you have an opportunity to actually get reduced burden from a financial standpoint. And this is very important for people who are making a way out of no way, as this student seems to be doing, working a job here, a job there to keep afloat because there's no generational wealth that they can rely on. A number of institutions have actually gone to offering decreased tuition, need-based tuition, free tuition even in many situations, to encourage the diverse individuals to apply who may be adversely impacted by an imbalance in wealth in our society. So I think that's a hugely important thing. The costs of education have skyrocketed. And just this past month, there was a brief bit of respite for $10,000, but that's not nearly enough to cover what is necessary to help many people do well in terms of the academic dysfunction that exists.
Absolutely. And I even want to add to that many of our residents, particularly those coming from underrepresented backgrounds, are graduating with debts that are mortgages, right?
Yeah.
So $300,000, $400,000. And that really determines what kind of residency and specialty they're going to go into. You know, how is it that we're going to increase primary care physicians if they are carrying such a load and a debt, at the end of their training? I want to piggyback off of one of the questions and just add to it. Let's talk about allyship, right? And so we talked, about what some of our colleagues who are underrepresented in medicine are doing, right? Taking on these diversity roles, the research that they're doing, and, even working within the communities where many of our patients who are underserved in medicine are. But what about allyship? What can our other colleagues coming from the majority community do? And they may be colleagues or even our other leaders coming from the majority community do. So I want to make sure that we touch upon that.
Well, one of the things that I think that's interesting is the equitable practice of training. We actually have in our requirements that every resident should receive an individualized learning plan. And many people come in and they're not the best test takers in the world. And so let's find a learning specialist to help them identify their learning needs. But what about those people who come into residency with a deficit in compassion, thinking about what they're going to do when they're finished and don't think that they're going to actually use it to offset a difference that exists in society that they can actually improve with the skill set they've developed? What are we doing to help them in our programs? I think it represents a great opportunity. I told you about the MSQ, the Michigan Student Questionnaire, and the GQ, and how there's been no progress with the percentages of white and Asian students over that period. We've missed an opportunity by not helping them to develop the compassion that one needs to be an effective physician. And while we're looking at people who do very well in standardized exams and holding them up as the model for what we want, what we really want are people who are going to serve the underserved, who understand from a compassion point of view that they have to care for all patients and actually treat people with the humanity that everyone deserves.
You know, as you talk about that, I think that it's this understanding that we need individuals that may have multiple and varied career trajectories. And we need them. Not one is more valued than the other, but we need them. But as part of our education and training, people should be coming out with a respect for and appreciation for the other paths that they don't take and why it's important and how they can contribute in those spaces. For part of allyship, because allyship is not, to me, just about those who are not minority and what can they do. If you start to think about intersectionality, there's the allyship all over the place. Yeah. Is it sexual orientation? Is it gender identity? Is it race, ethnicity? Is it country of origin? Is it economics? Is it disability? There's all sorts of ways, and that we have multiple identities. And if there is any space, to me, the health professions is a space to understand and to recognize this, because our patients have multiple identities. And in part of this education and training and increasing awareness and compassion for and recognition of that I think Dr. McDade, is how I interpret part of what he's talking about. It's understanding that you need it for your patients, but you also need it for your colleagues and the people that you work with, and valuing that at the same time. And so allyship, to me, should come naturally to us, because part of this, there used to be, I remember early on, when people would talk about cultural competence and training. I'll give you this example. And it was being added more and more to medical education. And I was talking with a group, and I was talking something about custodians and other things. And they said, you know, Joan, you're always pushing the envelope. We're doing it with our medical students for how they work with their patients. And now you're talking about these custodians and the other people who work in the building. And can't you like let something ride? And my comment was, what happens if the custodian comes back for your evening clinic? And it was like, oh my gosh, we're talking about the same people. The health professions, we have this amazing opportunity to understand that we work with all elements across the full spectrum of society. And the values we're talking about are valuable for all of those spectrum, across that full spectrum, in terms of equity and in terms of justice. We say it, but I don't know that we train for it. I don't know if we educate for it. And to me, that's part of it has to be imbued in the education that we put forward.
And Joan, as you were speaking, I was reflecting, when you talked about the fellowship, I thought about the benefits I've had in a fellowship. And the Robert Wood Johnson Foundation sponsored my fellowship, and they had a tagline they used to use as a proverb. I believe the source is unknown. If you want to go fast, go alone. If you want to go far, go together. And I believe today we're challenged to go fast and far. And if we don't go together, we are not going to make the progress. So, and as you said, not just together as health professions, but as individuals and organizations. When we started well-being, we focused just on the person. That's insufficient. I can take the best care of myself, but if the system around me isn't supporting me, it's limited progress. So I like that. Let's go far and fast together.
Thank you.
Well, I hate to say this, but I'm afraid we're going to have to wrap up because it's been just a wonderful conversation. And there's so many more questions and comments that we haven't had a chance to address. But you will see a recording of this webinar on our website tomorrow. And we'll post some articles that our guests and panelists have sent to us. And you can take a look at those. But I've heard so many really important points made, from the social determinants of health professional education to how to apply the stuff that we're doing that we know how to do in quality improvement to education. You know, starting with the data, moving through small tests of change, perhaps, or setting expectations differently, measuring the results, and so forth. I think there's so many questions, but I think the most important thing to think about is that you cannot have compassion in this world without diversity and equity and inclusion, and addressing all of the disparities that affect us all. And we need to do it together as a combined force for compassion in the world, rather than existing in our silos, as to some extent we have in the past. So I want to thank you all so very, very much for participating in the panel. I want to thank everybody who attended. It was terrific. Please keep your eye on emails also for the next webinar we're going to have, which will be really fascinating, on shame in medicine. And keep an eye out for the announcements about our annual Kenneth B. Schwartz Compassionate Healthcare Dinner coming up in November 3rd in Boston. And take a second, please, to fill out the brief survey that we'll send you after the webinar. We really appreciate your feedback, and we look at all of it. So thank you again to all of you, and have a great rest of your day.
Thank you.
Thank you.